I'm excited to introduce our speaker for tonight, Dr. Leonard Chuck. Before joining Diablo Medical Research, Dr. Chuck was in community practice for 20 years as an internist, and prior to his community work, Dr. Chuck spent 10 years as a clinical laboratory researcher at several major academic institutions. Dr. Chuck joined the Diablo Clinical Research Team in 2006, and in 2007 became the co-medical director and is the principal investigator for most of their research studies. Tonight he will be talking about the physiology of type 1 diabetes and how you can use this information to make more informed decisions about your treatment plan. So without further ado, I'll introduce Dr. Chuck.
Thank you. Great. Yeah. I know most of you, especially in this family, so it's great. And I know Teresa and Eva, I met, they came in to be part. This is a dedicated clinical trial center. And all we do are clinical trials. We don't practice medicine here, we're actually doing testing. And I've been fortunate to be involved with this group in that my background, with Leah told you I was on the bench, that those are where the real nerds sit. It's workable looking as public. So I'm a real scientist. And so I have to define that. Because one of the times with my kids, and we had a back to school night. So my daughter gets up and she says, well, the other kids get up and say, oh, my dad's a fireman, my dad's a policeman, and so you can understand that. But my daughter gets up and she says, my dad's a scientist. So the other kids say, well, what the heck's a scientist? She thought that kind of stumped her. So she thought for a second and she says, oh, a scientist is a person who doesn't know anything. But trying to find out. And so that's my background. I'm a scientist, I'm a scientist through and through. And I know, there's so much to know that that you can never know everything. And we're trying to find out. So I practiced internal medicine here at John Muir for 20 years, and then came to join this group and actually began learning about diabetes. So my background is actually as a physiologist, and that's what I'm going to talk to you about. And as a physiologist, having taught, was part of the physiology department at UC San Francisco, in the city, and part of the Cardiovascular Research Institute. My background is actually in cardiovascular electrophysiology, very, very different. But when I came here, I started looking at diabetes because we were doing several studies in diabetes, and I began getting interested in excitation and secretion coupling. How is it that you actually, what drives the secretion of insulin and amylin from the beta cell? So that's what I'm going to talk about. And Leah asked me to talk about type 1 diabetes. Hazel and Mary and Keiko have heard about that. When William first got his diabetes, they came, and at that time, just several years ago, 3 or 4 years ago, yeah. And at that time, my colleague very graciously told them, diabetes through the adolescent years you just have to pray because you don't know what's happening and things will surprise you. And I kept thinking about that. That didn't sit well with me. And so I began looking at type 1 diabetes. And literally, this is the first talk I'm giving just on type 1 diabetes because I think we've learned enough, and we're beginning to learn so much more about this particular type of diabetes. It is very different from the vast majority of diabetes, which is type 2 diabetes. And people don't normally know that of the diabetics in this world, what percentage are type 2 diabetics?
90. 90.
Higher.
95?
92 to 94% of all diabetics are type 2 diabetics. 92 to 94%. That's like almost all diabetics. And yet we treat everyone like a type 1 diabetic. And that's what's so different. And that's almost, like how is that possible? Because type 1 diabetes presents so abruptly, and with diabetic ketoacidosis, it presents almost in urgent fashion. So that when you actually have a diagnosis with diabetes, it's really, we're finding it's really frightening for most families. They say, what? I have diabetes now. What do I do? Am I going to be very different? What do I have to do in life? How is it going to change my life? And in many cases, it changes a lot. And Leah's done, she is a type 1 diabetic, and it's a major change in your life, what you're thinking. So I'm here to tell you, that list I gave you here is what I want to talk about, and that's how we're going to go through this. So that's why the title is the top. So you got type 1 diabetes. And so I wanted to put it in there and say, put a comma there and say, so you got type 1 diabetes. Now what? And that's the way I want you to approach it. And because I think one of the things we're going to talk about, my views of the people with type 1 diabetes, the first thing that is really important, and I want William to hear this. When you have type 1 diabetes, there are no restrictions on what you can do in life. You want to be the President of the United States? Go for it. You want to be the Chief Justice of the Supreme Court? Go for it. There is nothing you can't do. You can be a marathoner, and what's his name? Is it Jason Morris, or just from Stanford? He was a type 1 diabetic, and on the national team. He's into soccer in a great way. There is nothing you cannot do as a type 1 diabetic. So and the other thing is that, the second point is that you need to learn that you're going to have to learn how this system works so you can treat yourself. And that's not only for your mom and your grandma and your grandpa, so they can sleep at night. But you're going to learn what you have to do, because you're the only person that knows what you do in the course of the day. And once you learn what's important in diabetes, you have full control of how you deal with your diabetes. It is a condition. It is not it's not a disease in a sense that there's nothing wrong with you other than the fact that you don't produce some of the hormones that you're looking for. So the self-sufficiency in diabetics is really something that we want to encourage, because that's something you're going to have the rest of your life. And once you learn how to deal with it and control it, then everything works a lot easier, and especially for you. But the last point that I'm going to try to, I won't harp on it, but I've been told that diabetes is really punitive. When you get it, you say, oh my God, you can't eat sweets, you can't exercise all the time, you can't eat all the rice you want. I mean, you got to check your sugar all the time. You got to give your insulin all the time, and you don't want to go high, you don't want to go low. You want to keep your A1C low, but what happens if it goes high? You don't. So it can be punitive, but I'm going to show you that it is not. This is something you actually do. So what I'm going to talk about is to explain to you, and really most of this is physiology. Where does the glucose come from? Where does it go? How do you actually move it? Then we're going to talk about what is type 1 diabetes, and we've learned a lot. Then we'll talk about how you treat it, the parameters with which you treat it. And then I'm going to talk about and offer some suggestions or ideas about how we can actually, we're going to improve the way we treat diabetes, because we can actually control other aspects of diabetes other than just with insulin. It is a multi-hormonal disease. It is not a single hormone. And that's not always understood. So let's start by going through and talking about where glucose goes. Where does it come from? Where does it go? And this concept of making room for the sugar that you put in. Glucose moves by diffusion. As my friend said, what is diffusion? I'm from Hawaii, so that's what I'm saying. But what is diffusion? So I need to teach you that concept. So glucose diffuses and moves from a high concentration to a low concentration. That's the process of diffusion. So if we look at this, just out of an example here, this being the outside of a cell, and then this being the inside of a cell, and here's the cell membrane. So you start in this component here where you have all of the glucose stuck outside. These are solutes of glucose, being one of them. And then if you have pores or openings and you allow that glucose to flow, it will flow from high concentration to lower concentration. That's called diffusion or movement, to a point where it's equal number on either side. That it wants to get to an equilibrium so that there's no there's no push for the sugar to go from high concentration to low concentration. That's the concept of diffusion. And the difference between the difference between the concentration outside and inside, or one area and the other area, is called the gradient, or the glucose. In this case, the glucose gradient. And that's something we'll harp on, and we'll come back to a little later. So here, in this case, you see it has. This is where you have a high glucose gradient, high concentration outside, low concentration inside, and then it perfuses. If you make openings and allow it to come in, you open the doors and let it come through. It'll flow into the low concentration, and eventually get to a point where it's equal on both sides, and now there is no gradient, or no difference in the two. So it moves into and out of the blood. So let's ask the first question. How do you get glucose into the blood? Where does it come from? And people look at me, and especially when I talk to diabetics. You did it when we talked to you, right? The food. Yeah, you're right. You're absolutely right. It comes from food, and it comes from, in particular, it comes from the carbohydrates, because the carbohydrates eventually end up as glucose, and that's how you get it into the blood. What kind of food are we talking about? We're talking about simple carbohydrates. Simple carbohydrates are simple sugars: glucose, fructose, and galactose, the three hexamers. Then you have the double glucose, the double sugars. Table sugar is glucose and fructose. Lactose in milk is glucose and galactose. And all the starches break down to a double glucose, which is called maltose. So you have these what we call disaccharides, or double sugars. And then in your intestine, you have an enzyme that breaks them down. Sucrase breaks down glucose into glucose and fructose. Lactase breaks down lactose into glucose and galactose. And maltose breaks down the starches into a lot of glucose. And that's why you have people that are lactose intolerant, because of where that enzyme sits. And when you don't have that enzyme, this double sugar gets into the large intestine, and then the bacteria love it because they break it down and use it to grow and cause all that gas. That's what lactose intolerance is all. Right? But you can do it with lactose, you can do it with sucrose, you can do it with maltose. If you have celiac disease and you don't have any of those enzymes, that's what you end up with. So then you have the complex carbohydrates. You know, the lentil, quinoa, bulgur, brown sugar, whole grain, all the things that I never eat. And then you have the great white stuff, all the really good stuff, right? I mean, the pizza, the white rice, all the stuff that's really good, right? Yeah. So that's great. Yeah. So now then the question is that you get sugar from the food. But do humans have any stashes of glucose from which they can actually take that glucose and put it back into the blood? No. It must be something, because otherwise I wouldn't ask the question, right? So, and the answer is yep. And that stash of glucose is called glycogen. Glycogen are long chains of glucose. And what the body does is, like a Lego, it knocks off that glucose one by one. And so where are these stashes of glycogen? Or where are these stores of glucose in the body? Liver. The liver is able to take that glycogen, break it down to an intermediate compound called glucose 6-phosphate, knock off that phosphate group, produce the glucose, and then there's a hole that it can come out of the liver and into the bloodstream. And what happens is that there are 4 hormones that help you get it out, the most important of which is glucagon. So, and you know that, William, because when you go low, and you get hypoglycemic or low sugar, what happens? You start to shake, you perspire, you feel like crap, your heart's racing, right? Why? Adrenaline. That's adrenaline. Your body senses that, your body knows that, your body reads that in your brain, in the hypothalamus, and it picks up on that and says, wow, we need more sugar. So where are we going to get that sugar? We've got to go to the liver, and it stores the sugar in the liver, and we're going to try to get it back into your blood, and that's what happens. So once you're having that reaction, you start to perspire, you know your body's trying to build it back up. But typically what happens when you get to that, you feel so bad and you're so low that, you know, grandma gives you like 14 cookies and 3 bottles of ice cream, and you go, woo.
We went low today, just so you're saying that.
Right, that's what happens,
Get
right?
a shot of
That's
mini
right.
dose,
Oh,
yeah.
Yeah,
Yeah.
right. And you get a shot, right?
Yeah.
What's in the shot? Glucagon. How come it's not adrenaline? Because that's what it is. How come it's not sugar? I mean, it's low sugar, right? So why not take the shot and give yourself sugar? Isn't that weird? That's the same question I asked. Why do you give glucagon? Well, glucagon always is able to actually drive as much sugar out of the liver as you can. Here.
Would you say that again?
The glucagon is that hormone,
Yes,
and it actually is able to drive the sugar out of the liver.
out of the liver.
The liver has the stores of glycogen,
Yes.
right? It's able to activate, and it's the most powerful drug that does that.
So that when you are real low, you want that.
You can need to bring it up, right? Yeah, the body likes to live above 72 milligrams per second. And so when it gets below that, your brain senses that, and because it reads it there. And then once it gets below, it gives off the signal, and it produces glucagon, which is from the alpha cell, a different cell in the pancreas. And you give off some adrenaline.
So we don't know how much glucose lives in the liver then?
We do? Yeah, we're getting to that.
Oh,
That's it.
sorry.
Can I ask a question? So
Yeah.
if your pancreas isn't working right, it's not producing the correct amount of glucagon to keep, like for instance, today Will dropped 37, which is
Right.
pretty,
No, that's not, no.
yeah.
The
Not good.
glucagon, it's there and it's functioning, it just it hasn't reacted yet.
Okay.
It requires the brain stimulus to actually
So
drive
the
it.
shot that I give him, the mini dose of the, you know,
We'll take it all in the liver, and it'll bring it right back up, very quickly. That's what your body is. But there are actually 4 hormones that do that. The other interesting one is growth hormone. Growth hormone, when you release growth hormone, it actually drives the sugar out as well. And that's important in an adolescent, because you're gonna have these bursts of growth hormone. And then, during those bursts of growth hormone, your sugar level is gonna go up. And so you'll see that. So don't be frightened by it. It's just, oh, that's what's happening. But you can tell when you have growth hormone, because the way you release hormone, growth hormone, is you get it in REM sleep. So when you're really sleeping, you get a lot of growth hormone. And that's for your mom and dad, so they know that when you're really sleeping, you're actually growing. And so that'll make you want to go sleep more. So when they tell you to go to sleep, don't fight it. You're looking for growth hormone, right? And then cortisol. Cortisol is a steroid from the adrenal gland. You do that in times of stress. So if you have a cold, or you get an infection, your body senses that, or then you build up your cortisol. You got something that's really getting you anxious. That's cortisol. That'll drive you up. So those are the 4 hormones that get it out of the liver. The glucagon and the adrenaline do it immediately, much quicker. The cortisol and growth hormone are long-term effects. They're a lot slower. So that's one of the stores of glycogen in the liver. But where are the largest stashes of stores of glycogen in the human body? Well, it's in the liver, but that's not the largest one. Muscles. Your muscles, you need it for the fight or flight reaction. Because a predator comes after you, you either fight him or run away. So the fight or flight reaction is what dictates that the muscles have to have a lot of sugar. How much? About 4 to 5 times more sugar stored in a muscle than in the liver. So, when you have a hypoglycemic episode, you take that sugar out of the liver. How come? Why not take it out of the muscle? It's got 4 to 5 times more sugar. So why don't you take it out of thing that has a lot of sugar? Why? You can't. You biochemically can't do that. Your body's structured. You don't have the enzyme that allows you to get that glucose out of the muscle. You don't have what's called glucose 6-phosphatase. And that's the enzyme that breaks off this phosphate group and then allows it to become glucose that comes out of the glucose pore. It's too big. This is something we learned in the first course in biochemistry that we promptly forget when we actually begin working on diabetes. And so when you go back and study it, you say, oh, that's why that's there. Everybody has this. Non-diabetics, everybody's like this. You can't get that sugar out of the muscle and back into the bloodstream. So what does that mean? The muscles are one-way storehouses for sugar. You put sugar in there, it gets trapped in there, can't come back out. What does that mean? one way to store it. That means that you have to use your muscle, draw down that sugar, and make room for the sugar from the blood to actually get the blood sugar to drop. So that's the major concept. The exercise is needed to make room for sugar. Every diabetic needs to know that. That's why you exercise. You don't exercise because we tell you that's what you need to do. You're exercising so you're making room for the sugar you're putting into the bloodstream. So if you eat a pizza or you have some pasta and you have a lot of sugar, what do you have to do? You've got to use your muscles so you can draw that sugar down. And the more you eat, the more you draw. Right? So that's why, and you want to make it fun. Do things that you really enjoy. And I give this talk on type 2 diabetes. And so and it's the same process occurs. And so you walk, run, aerobic, and for shopping is really goes over well in the type 2 diabetics.
Dr. Chuck,
Yeah.
I'm confused though.
Go.
If you're drawing out the sugar from your muscles though,
Yeah.
shouldn't that be spiking your blood sugar though?
No, you're drawing it out of the blood and putting it into the muscle. But you're using the exercise to empty it out of the muscle.
Okay.
So you need to refill that store because you need it
So
for
it's
a
drawing it back in?
It draws it. You're
So it draws the sugar.
You're replenishing the stores of sugar in the muscle because you need it for a fight or flight reaction.
So that's why he drops.
That's
when
right.
he exercises.
That's right. That's right. That's absolutely what you. So the idea is that you have to use it. Yeah.
But then there's that phenomenon that if you exercise, your sugar levels go down because.
The blood sugar goes down, right?
Yes.
Why? Because you just drawn it into the muscle. That's exactly what we're talking about.
So you're taking it out of the bloodstream, putting it into the muscles, which cause your blood sugar level
No,
to
it's
drop.
the other way around.
Other way
It's
around.
in the muscle, right? You have stores of glycogen. You use your muscles and you draw the glycogen stores down.
Yes.
So now you need more sugar to replenish it, right? Where does that sugar come from? It comes from the blood
Okay.
and it goes into the muscle.
Okay.
That's why you
Makes
drop.
sense? Right, and so you're taking out of the blood into the muscle, and that's why you drop in the blood.
Okay.
Make sense? Okay? And that's curious because, when you exercise, one of the first things you do if you go into hard exercise is, it's a stress. And so what you do is you produce adrenaline. So your sugar level initially goes up. But you make a hole in your muscle and then it goes down. So it's biphasic. It goes up initially when you're exercising and then it goes down. So you have to know that change to understand where you're going high. And so some people tell you, well, don't exercise when you're high. Well, that's crazy, right? Because you have to have somewhere to go. But you also know that when you give insulin and nothing's happening, if you walk the person around the block, that sugar drops. Like, how does that fit? Well, it fits with this idea that you take the sugar out of the muscle, and now you have room for the sugar. So this concept of making room for sugar is really essential in a diabetic. That's
Is there
right.
such a thing as too much exercise?
Yeah, you can draw it down too far. So we had a guy that actually rode across the United States on a bicycle. He was usually on 4 units Lantus, basal insulin. When he rode across the U.S., 0 insulin. If he took 1 unit of insulin, he'd go too low. Right? Does that make sense? We also had a lady who's been here, not for a long time, but she came to us as a diabetic, and she had no insulin stores. Her C-peptide level was 0. Actually, it's 0.06, 0.026. And then we stimulated with sugar, it didn't change to 0.026. She had no insulin. So what she would do is she would run every day. She'd run 3 to 4 miles, and she could run at 6 minutes a mile. So she was running. She limited her carbohydrate intake to 75 grams of sugar a day, and her hemoglobin A1C was 5.7. She's about a size 2. She's a financial analyst. She's a certified dive master. Just a wonderful person. But she just with no insulin. When you gave her insulin, she'd go low. And most of the endocrinologists looked at her and said, "Oh, she's a crazy lady." But I looked at her and said, "Well, she's telling us something." And so what I drew from her is that That's what some of this idea comes from. That's where the sugar is going. Okay? So you need to make room for sugar.
So they tell you that when you go to the gym to take one of those energy bars,
Yeah.
so halfway through, you're probably going low.
Could, well, it depends on how hard you're working. Yeah. And you know, when you have a continuous glucose monitor, you can see that. You can monitor that. And you can tell for yourself what that's.
Right.
Very, very helpful. Tracy, did you have a question?
Yeah, well, I actually had two.
Good.
The first one was when the sugar leaves your muscles when you're exercising, where does it go? I think that's the
You use it for
confusion.
energy.
So you just kind of pee it out?
No, you use it for energy.
So it's used by
Your muscle.
your muscle uses it, and it
Yeah.
just, so it goes away that way?
Yeah. You break the glucose down. Glucose is in cells to provide energy, to produce ATP.
Okay.
Right? So
Okay.
you're using the muscle. You require the energy, so you draw your glucose stores now. Yeah.
And then were you saying that that woman has type 1 diabetes,
Yeah.
but she doesn't take any
She doesn't take any
insulin
insulin.
whatsoever?
Yeah. Isn't that crazy?
Yeah.
This is something you've never heard of that. Right? Most people haven't heard of it. Most of the endocrinologists said that's not crazy.
So she's a type 1, even
Yeah.
though she's got a low A1C, takes no insulin.
Yeah.
What makes her the type 1S? I mean,
She had the antibodies kill
Okay.
the beta cells. She has
Okay.
no beta cells.
there you go.
Right?
So,
We'll get into that.
so if she has no beta cells, her body's not making insulin.
Yeah.
How does the glucose get into the cells? Into
It
the rest of the
diffuses.
cells?
It diffuses it. Because the glucose gradient is such that it draws it in.
Okay.
Right?
Yeah.
I'll show you in a second. Yeah. This story gets even more interesting. Yeah. So, yeah, you make room for sugar to create that glucose gradient. And the interesting thing is that muscles, as I say, they get first dibs at all the glucose. They take 80% of all the glucose you take in, right off the top, because they need to reestablish that baseline level. It's a mandatory thing. It's fight or flight. And in the old days, when the Tyrannosaurus Rex took off after us, the ones that didn't have any sugar, they ran out of energy, and that's what you call food. Right? That's it. That's how you know that. Yeah.
It's like Stuart will carb up, like
Yeah.
before a marathon run,
Yeah.
right? He ate a lot of pasta and rice
Yeah.
just to carb up the night before,
You hope
so
it goes-
that for his marathon run the next day,
He
he
hopes
would
he-
have the energy.
He's hoping it's going to his muscles.
Yeah, I know.
Yeah.
Hoping,
That's-
keyword hoping.
But that's, so that's what makes
Yeah,
sense,
that
then.
is, that-
You're storing it up then, right?
Yeah, you're right, yeah. So and the glucose gradient, the difference in the glucose level in the bloodstream versus what's in the muscle dictates how much sugar you draw into the muscle. So what happens if the muscle's full of sugar and you don't exercise and it's all full of sugar? Where does the sugar go? Nowhere. It stays in the blood, right? And then here, so what you look here, this is a diagram. That's muscle, and the green is the glucose, and this is the glucose in the blood. If the muscle has all this sugar, there's no way for that sugar to go. But if the muscle is empty, then it draws it down quite well, and that's what dictates, that gradient across the muscle is what dictates how much sugar you get. So no room for sugar, yeah, you go high, low, you go high. And you can get as much insulin as you want. You can open all the doors you want, but there is nowhere for that sugar to go. So let's move to the next step. What is type 1 diabetes? And we've had to learn about the immune system since about 1980. We now know that the immune system is what kills the beta cell. That's what type 1 diabetes is. It's an immunologic disease, otherwise known as an autoimmune disease, because you're attacking your own body. So what it does is it kills the beta cell, which produces insulin and something called amylin that we'll get into in a second. And it slows your ability to take sugar out of the bloodstream and put it into cells, because you don't have as much insulin. There are not as many openings into cells. And these are the antibodies that we have identified. The Robert Davis Center up in Colorado is a great center where they actually look for all these antibodies. There are 5 of them that we currently understand. Anti-glutamic acid dehydrogenase, anti-islet antigen, the islet cell autoantigen, the cytoplasmic antigen, the zinc transporter. We have antibodies against them, or they actually have antibodies directly against insulin. What does the beta cell produce? It produces insulin, but it also produces something called amylin. and it does it in a 20-to-1 ratio. They do different things. So then the next question we need to address is, how does insulin work at the level of the cell? What is the insulin doing? Why do we need it? So this is a diagram of how that insulin works from a physiological view in 2004. Here's the insulin. It attaches to a receptor that sits across the membrane. When that happens, it triggers a cascade of enzymatic or biochemical steps. And what it eventually leads to is this protein kinase B, otherwise known as AKT, and actually protein kinase C. And what it does is it takes these groups of pores, they're called the GLUT4, the glucose transporter 4, and they sit in little groups, what we call micelles. And what it does is it takes it from around the nucleus and brings it right up to the surface of the cell membrane, basically punches holes into the membrane. It's like putting doors into the wall of a building. And that allows the sugar to come through. So what it's doing is changing the permeability or the ability, the porosity of the membrane to glucose. And so that's in the cell membrane. So that's the process of what insulin does. But I want you to also take a look at, they stuck this thing in here that nobody ever talks about. You can actually do this same thing and bring these same glucose transporter 4s up to the surface of the cell with exercise. That's amazing. No one ever talks about that. And this is becoming very, very important. So these are just telling you what they're doing. So the insulin actually brings pores to the wall and allows that glucose to flow into cells. It's like opening doors that will open either at a department store or a home, and it lets a crowd of people come in. And by the same token, if you open a lot of doors to a department store, but the store is full, there's nowhere for you to go in. And the more you open, the faster you go in. Right? But what dictates is whether you want to get in. So insulin really just allows sugar to come down this glucose gradient. It does not actively drive sugar into cells. That's something that you're going to have to put your head around. It is not active transport. You don't drive it in. It's by diffusion. So how does exercise work in a cell? It works just like insulin. So that means, what does that mean? It means when you're exercising, it's like giving yourself a little extra insulin. That's going to help you understand what happens. So exercise allows that glucose to diffuse into cells. And it does it by a different mechanism. Here's the insulin receptor, and it brings that GLUT4 transporter up to the surface to punch holes in there. Exercise does exactly the same thing. This is from Laurie Goodyear from the Johnson Clinic in Boston, who's beginning to actually move this idea. Here's a little more extensive explanation of that. This comes through AKT, or protein kinase B, and then here is AMPK, which is a different enzyme. But they do exactly the same thing effectively. They both facilitate the passive movement of sugar into cells. This is an explanation, a diagram of how you have facilitated diffusion, where when you have a compound like glucose, and it gets here, it kind of drives it in. It allows it to go in. It just helps you go in. So it facilitates the movement. It makes it easier for that movement of glucose into a cell. It facilitates it. But it's clearly a process of passive diffusion. So here are the ones where it's passive. It's run by mass action. There's straight diffusion across the membrane. Here through a pore, or facilitated where it's actually helping you get through. In contrast to what happens when you need to go against or put it into an area that has higher concentration, you need energy to do that. It's like you're taking a shovel, throwing it over the wall so you can actually build up what's on the other side. That's active transport. Very different from what happens with insulin and glucose. So the things that work by simple diffusion, water, otherwise known as osmosis, these univalent cations, oxygen and gases will move. And then facilitated diffusion, you see mostly glucose, and then with active transport, large compounds, proteins, amino acids, fatty acids, and some of the bigger compounds. So the idea is that the insulin helps the rate of glucose movement to the cell, but the gradient is what dictates how much you move. it facilitates it by actually, it's like opening doors. So you get that idea, then you understand how fast it's moving. So the amount, the gradient, the glucose gradient indicates how much goes in, and that's really important too. It's a very big difference. What creates that glucose gradient? Again, making room for sugar. Yeah, so making room for sugar depends how much you actually put in there. So, I've told you, if your muscle's full of sugar, no matter how much sugar insulin you put in, it's just not going to go anywhere. And you'll hear this concept occasionally where you talk about, even with a lot of sugar, a lot of insulin, the sugar doesn't go anywhere, so they say you're insulin resistant. But part of that is because there's no room for it. So now let's ask the other question. I've talked about insulin, but what other hormone comes from the beta cell? And that's this thing called amylin. This is a hormone you rarely hear about. It's the 1 to 20 ratio. And it does three things. It decreases the amount of glucagon that's released after you eat. So therefore it decreases the glucose input. It slows the emptying of the stomach, and thereby makes it harder for the sugar to get in. And also hits the satiety center in the medulla, and so you don't eat as much. You get full faster. Again, you decrease glucose input. The interesting thing is that we're learning that type 1 diabetes is not only one hormone. It's more than insulin. And it's at least 3 hormones, if not others. Insulin is one of them. It allows the sugar to get out. Amylin, which decreases the input of sugar. Glucagon from the alpha cell, which increases the sugar input. And some of the others are somatostatin, maybe even leptin, other hormones that we're beginning to look at. They're just not there yet, but right on the horizon. And in the next 5, 10, 15 years, you're going to hear a lot more about that. It's going to make it more complex, but easier. So this is a schematic of how these things work. Here, the sugar comes in from your stomach with carbohydrates. It comes from the liver on a basal rate all the time because the glucagon from your alpha cell is always driving us out at a constant rate, or all the time. And then it gets into the blood, and then it goes. The insulin helps it move into the muscles. When you produce insulin, you also produce amylin, and the amylin does those three things. It decreases it slows the emptying of the stomach. It hits your satiety center, but the more important thing is that it drops the glucagon, so you don't drive as much sugar out of the liver after a meal. And the interesting thing is that I'm going to talk about this compound here called a glucagon-like polypeptide that comes from your intestine. And this is the compound that's really important in type 2 diabetes, but what we know is that it does exactly the same thing that amylin does. So it actually slows or decreases the production of glucagon. It slows the emptying of the stomach, and it hits your satiety center, so you eat less. So glucagon and amylin are very, very similar in their activity. The GLP-1 also increases the release of insulin, but that, in terms of this diagram, is not as important. And the alpha cell produces the glucagon, which drives sugar out of the liver. So when you're dealing with this, there's it's always, glucagon is always driving sugar out of the liver. So that glucagon production is actually what's driving what's called the basal production of sugar out of the liver. So the interesting thing in titrating is that what you're trying to do is you're going to titrate the basal insulin to deal with the basal production of sugar. And what we're talking about is that sugar coming out of the liver. So that'll help you understand what it is. So let's move to how we actually treat this bloody thing. And the principle of titrating is that we're going to titrate the output, the glucose output, to match the rate at which you get glucose in. So that's what I'm going to review. You match the basal insulin to the basal production of sugar from the liver. You match the bolus of insulin to the bolus of fruit sugar you get from the carbohydrates in the fruit. So basics, when you start with the basal insulin, is you titrate it based on how much room you have and how much extraction you have. And then you're titrating it till it's coming out of the liver.
What does titrate mean?
Adjust, or you control. That's the whole. When you're working with diabetes, you're you're supposedly trying to control what the sugar in your bloodstream. And thank you, because in medicine we use that term so commonly. We just did a lot of things here. So thank you for answering your question. And the boluses are with the food. You adjust your insulin dose based on how much carbohydrate you get in food. So let's start with the basal. How do you adjust the basal? What do you look at? So that's when it's coming out of the liver. So when in the course of the day is the sugar only coming out of the liver? Well, overnight when you're sleeping, because there's no food, right? So you have to be beyond that period where the food's coming in. So you're looking at 4 to 6 hours after a meal. So, they used to suggest that you actually you probably took snacks at bedtime. Well, if you take a snack at bedtime, you got no clue as to what's coming out of the wrong. So if you don't have a snack, you look at your sugar before you go to bed, and then you see what it is in the morning. You see that's the time you're asleep, and that's only basal, only out of the liver. And so usually the starting dose is, it's actually, they say it's 0.2 units per kilogram, which is actually 2.2 grams. So it makes it a lot easier if you go 0.1 unit per pound. I think we do it in the United States. So here, let's say at midnight or after all the food's gone, let's look at the sugar here and then see what it is in the morning. And that's going to tell you how this basal is adjusted. The idea is actually to wake up at the same level you go to bed at, because then you know that whatever is coming out of the liver is being put into the muscle at that rate with enough insulin. So if you wake up at a level that's much higher, blood sugar that's much higher than when you went to bed, then it's either because you had not enough exercise, and so there's not enough room in your muscle, or not enough insulin, and so it's harder for the sugar to get into the muscle, and so that's when you wake up at this higher. Contrary to that, if you exercise a whole lot, then you wake up at a much lower blood glucose than when you go to bed, because this is the period when there's nothing coming from food. So that's how you work on adjusting your basal insulin, and then hopefully you can get it so that it's flat all day long. And so you adjust.
So Dr. Chuck,
Yeah.
I think we adjust his basal in the morning
Yeah.
to give him more insulin in the morning, because we were told that he's insulin resistant, right, in the morning? Isn't that what?
Yeah, that's what it is.
So does it mean that
like-
he's actually retaining a lot of glucose in his muscle? Is that what's happening?
That's right, yeah, so he
And so
hasn't
it's
drawn it
just-
out. He
He's
hasn't
not
drawn
drawing
out.
it out, right? So then
Well, he hasn't
that's what's
exercised yet,
happening?
right? He's just gotten up, he hasn't moved, and so he's not drawing it. But what you'll do is, you need to adjust your insulin based on what he did the previous day, because that's gonna tell you where his baseline is. And you can notice on days that he's really active, you need to drop your insulin. We'll go to that in a second.
Okay.
Yeah, that's a really common question, because I've found that almost uniformly that, what you worry about is going low at night,
Right. Yeah,
right?
yeah.
And so that's what this is all about. So how do you figure out what to give? So you know you're not gonna go, well, that's based on how much room you make. And that's not something that people normally think about. They just look at a number, but they don't know what you've done. The only person, in William's case, the only person who knows what William's done is William. He knows how hard he's run, what he's done, whether he's rode his bicycle, he's been resting for 4 hours. You don't know. But then he knows what that history was for the previous day, so he can assess a rough estimate of how much room he has in his muscle. So then he can adjust his insulin. So these are a couple things. This is an explanation of that previous slide where in the morning the blood glucose is much higher than at midnight. Then you have much more coming in than going out. And either too little exercise or not enough insulin. And then in the morning, if it's much lower, then you've taken out too much room. And the goal is actually get it so that it's the same. And that's really different from what you normally see. So as an example, if your blood glucose at night before you went to bed is at 200 and there's nothing from dinner, you want to wake up at 200. Well, they're not going to tell you that. They're going to tell you, wake up here at 105, 120. So if it's 200 and 105, you can figure that out. You're just drawing too much. You're drawing down too much, and you need to decrease your basal. But here, if you're at 80 and you wake up at 140, 150, most people wouldn't increase their basal rate. You say, man, I'm at 80, Jesus. But most people at 80, they'd eat something, because you're worried about going low, right? But this will tell you, that's not a problem, you know, that they, it's what the insulin is doing, how it's working, and where it's going. So these are the different kinds of insulins that you'll see, the short-acting ones. And look, it takes about 15 minutes to begin to work, but it works for about 4 hours. And these are Humalog, Novolog, Aspart, Lispro, Pedra, and they're trying to develop. The interesting thing is that we've been trying to look at, the companies have been looking for insulins that work faster. So you say, work faster? Well, how much faster? It's like 6 minutes faster onset. You're like, well, you know, it's going to still work that long, and it's still going to do the same thing that insulin does.
Although I know other people like me tend to give themselves insulin just as they start to eat.
Yeah.
And it doesn't work, it
Yeah.
doesn't
Hello.
match.
Wonderful. We're going to get to that in 2 minutes.
Okay.
That's perfect. That's a great lead, yeah. And then here, the medium-active one, the NPH and Novolog, they work a lot longer. And then now we have some long-acting ones that work really great for the people with metered dose, you know, what you call it? They give themselves shots. The Lattice works for about 18 to 22 hours, with a peak at about 13 to 14 hours. In terms of, we're talking about the number of openings. The Levomer is a little shorter. The Tresiba, which is, this is Degludec from Novo Nordisk, that bugger works for like 60 hours and it's really flat for the 24 hours. That's an amazing drug. You get one shot for the day and it just, that's your basal level. It's really cool because you do that and you know it's the same whole day. And now you can see what happens when you eat, don't eat, when you exercise, don't exercise. There's some people who have pumps and they've got like 16 different basal rates and you wonder, how can you tell what's going on? You've got all these changes, you're changing them all day long. And so the problem is that you don't know where you are because you're changing the rate at which it's coming across. So you don't see that change with food. It's mitigated by the changing number of openings. So the rate is changing, so it's hard to understand what the actual flow of the dynamics are. And again, in graphic fashion, here you have, you know, the fast acting. It works 15, 20 minutes, 30 minutes, 50, and then after about 4 hours, it usually goes away. And then here, regular insulin is a little slower, and pH is a lot slower, peaking about 7 or 8 hours and gone by 12 hours. And then Detamir, which is Levomir, and then Glargine or Lantus, is longer. And then not on here is the Degludec, which is really flat, all the way right across. And there's some of the numbers that similar to what we just looked at. The one thing that you really need to understand is that it takes a while for the insulin to open those doors. It doesn't occur instantly. You know, they tell you, yeah, if it's high, give yourself an you expect it to move it. And so you're right. It takes 15 or 20 minutes, and you have to be patient. You have to understand the kinetics of insulin. You also have to understand the kinetics of the food. Food has a different way to get in. So that's what you do when you actually match boluses. You're matching the kinetics of the input, the kinetics, the ability, the way that the insulin works, the rate at which it works. And that's what you do when you titrate for the bolus. So when you're treating for the boluses or the food, there's several questions you need to ask. Like, how much insulin do you give? And usually you do that based on carbs. And then also, when do you give that insulin? Which is what you... And they're different. Most people don't even think about that. And the starting doses are usually 1 to 15, 1 to 10, and you adjust. Some people go down to 1 to 5, 1 to 6. It's varied. But a lot of that is clouded by the fact that they don't know when they're giving it. So the goal is actually what you want to do when you want. This is the blood sugar you hope to have, and so you want to have when the food comes in, you want to have the openings so the sugar can go out. And if you got a peg, the glucose stays. That never happens, right? But that's a schematic. That's where you can do these kind of things. Yeah, this kind of. So you're balancing the carbohydrate input with the glucose, the insulin to help it get out. But then remember that the output is really dictated by the glucose gradient that you need to always keep in the back of your mind. So when you administer the insulin is really key to the timing of the bolus. That's often not even considered. I mean, when you first started, they probably told you always take it either at the time of the meal or before the meal. Like, why would you? And I learned from a type 1 diabetic who came here, and she says, she was, she did, well, she would, whenever she had bacon and eggs, she'd say she would wait to give her insulin because she knew the food would come in later. And then, but the converse of that is that she learned that because when she was at an anniversary or a wedding, she was sitting with her boss who was a type 1 diabetic, and the boss says to her, the cake was coming out. And the boss says to her, "You can't eat the cake." And she says, "Watch me." So what she did is she gave herself the insulin, a shot of insulin, and she waited for 15 minutes. And then she had the piece of cake. She was fine. Just the same way, and then she learned that when you have bacon and eggs, you delay it. So the timing of the insulin bolus makes a huge difference. And you're just making holes with it. So this is in terms of the glycemic index. You have foods that have a high glycemic index and they come in quickly. Simple sugars will do that. Juice, all the simple sugars, glucose tabs certainly come in this way. More complex carbohydrates take longer, and they have the low foods that have low glycemic index take long to come in. That's why they're easier to work with. The interesting thing is that if you have fat in your food, or if you take an ounce of olive oil before you eat, it delays the emptying of the stomach. That means all the food and all the carbohydrates sit in the stomach and don't get to the intestine. And then when you finally release it, you get the same amount of carbohydrate, but it's delayed. So if you have like bacon and eggs, or you have that ounce of olive oil, wait to give your insulin. The timing, the connects or the change, the time period change.
What would be the benefit of delaying it then? Is it just, the benefit of the olive oil is just to delay it, but then?
But no.
Is it just, it's just delaying it, that's all, right?
Yeah, right, you don't usually do that. You don't usually do that unless you're crazy. But if you eat a meal that has like bacon and eggs,
Right.
and you have all that fat from it, that's when you delay it. Or if you have a meal that has a lot of oil in it,
Yeah,
or a lot of fat in it,
yeah.
you delay it. So you need to know the composition of the meal, and you'll learn that as you eat. So if you have a hamburger that's got full of fat, it's going to come in later.
Because it seems like for Will, that, like the complex, like let's just
Yeah.
say Chinese food, right?
Yeah.
Chinese food or pizza or things
Yeah,
like that.
yeah.
It seems to spike, we seem to spike like almost 2 hours later, or
Yeah.
an hour and a half
Well,
later. So we were looking
pizza.
at this. Pizza is like, it kills us.
What's on the pizza?
Pasta kills us.
Yeah, it's all the fat. You have a linguine Alfredo. Woo-hoo. Wait, and then when it comes in, and with the CGM you can see that. Test it, so you can see when it comes in. How long does it take for that food to come in?
So Dr. Chuck, would we be better off, because what we do is that we have a,
Split, dual weight,
we
whatever you want to
split
call
it.
Yeah.
Do people split theirs? We split ours, but we give some up front, right? And then you give the majority of it
You're hoping,
later?
with a little bit for what you get in quickly.
Would we be better just giving the whole later though?
Well,
I mean,
depends on what
that's,
you get. Some of it's going to come in early,
okay,
but much of that is going to come in late.
okay.
And so that's what you use the CGM for. You can see when the timing, right? Because the CGM is not in your bloodstream. That's the other thing you need to know. But it gives you that you use the CGM for the timing, and that'll help you a lot in terms of understanding when to give the insulin. So timing of the insulin, in addition to the amount, is really important. So, okay, but I put these together here. Here, if you give the insulin too late, so the food, you have something that has a high glycemic index and the food comes in here, so the blood sugar here goes up, and then the insulin starts to work here, and then it goes down. So it's biphase. By the same token, if you give it too early, it starts to go down first, and then when the food comes in, which is happening with the fat, it comes down. So the whole goal is, here, like, wait 15, 20 minutes. And as you do it more often, it gets really a lot easier. So some of the changes, if you increase your insulin, increase exercise, drop your basal there. If you increase, you've got a head cold, or you increase the sugar you're putting in, or a lot of stress, then you need to increase your basal, because there's a lot more sugar coming out of your liver. Decreasing, this is bolus rate, you drop, and then with a fat
delay your insulin.
Yeah.
And then if you have anniversary cake, give it early. Orange juice, the same thing. The interesting thing is that you're always worried about hypoglycemia. So can you avoid those hypoglycemic episodes when you really are exercising? That's one of the keys. And there's only one way you go low in bloodstream. People wonder when I tell them that. The only way you can go low in your bloodstream is you take out more blood, more glucose than you put in. And what you're putting in is coming from the liver. You can put it in by food, but that has a time course of getting back in. The rest of it comes out of the liver. So the only way you can go low is that there's a mismatch or imbalance of those two things. So if you're going to really exercise a lot, what do you have to do with your insulin?
Reduce it.
Bingo! See, somebody figured that out. We have an 11-year-old who figured it out. He was in soccer, he was a great soccer player, and they have these heavy exercises, and he figured out, when on the days I play with soccer, I need to drop my basic 1 or 2 units. It's fine. The other one we have in that study is a 15-year-old. He's first year in high school, and he noticed that when he went for phys ed right after lunch, he'd go low. So he says, all I have to do is actually decrease my pre-lunch meal by 1 or 2 units. He figured that all by himself. He never goes low anymore. And he's the guy with the hemoglobin A1C of 5.2. He wants that type 1 done. So, prevent just lower your insulin. Learn how much you lower your insulin, depending on what kind of activity you're doing. When you're playing soccer and you're running a lot, you're going to draw it down. When you lift weights, when you wrestle, I don't know what else you do, kendo or again, that's why those are the ways you change it. And the interesting thing is that you exercise depending on how much you exercise. Some of that exercise effort can last for hours to days. And that's what you need to know. So after you run your marathon, you'll notice, geez, it stays low because you're trying to replenish that. Okay.
So if the glucose is replenishing replenishing the muscle stores, does it actually make sense to carb up after a run instead of before?
Well, yeah, there's post-exercise nutrition that's very important, yeah.
So actually carbing up before the run wouldn't make any difference because there's no place for the carbs to go. The muscles were already full.
Depends on the kind of athlete you are. We talked about that. That's one of the things we're learning from the world of exercise physiology. It's really different. It's not, and that's becoming very interesting. So I'll talk to you about those are two different issues. So let's go to the last section. I'm going to talk to you about some of the things that may be coming up in the next 5, 10 years, 5, 10, 15 years. So we've talked about insulin, and it's always thought that diabetes is insulin, but that helps you get sugar out. Let's talk about the ways you can actually change the input. Because when William goes through adolescence, there's going to be times when he's got to go to a pizza party, right? And you don't want to not go to the pizza party. That's part of that first thing is there are no restrictions in your life. You just have to learn how to deal with these situations. So part of that is that if we can limit the amount of sugar that comes into you when you go and have a pizza meal, then it'll be a lot easier to treat. So isn't that strange? We've had insulin and amylin all along. And we found amylin, basically in the early 90s. But we replaced the insulin, but you don't replace the amylin. So why do you expect to get full control of this process if you're only replacing 1 of 2 hormones that are necessary? So one of the ways you can actually improve your working with this is to get back amylin. I was telling Leah early on, we had a guy who actually came and showed us how to use the Animus pump. He was the general manager for Animus. And the Animus pump is a really great insulin pump. So after he was done, I said to him, George, that's a fabulous pump.
but where's your pump for amylin? And he looked at me and he says, dang, he says, funny you should ask. So he says, this is my insulin pump, this is my amylin pump. Well, he's a general manager, right? So he had two pumps, one for insulin, one. So I asked him, well, so what does that do for you? And he says, well, it's allowed me, he says, it's amazing, it's really freeing. He says, I eat French fries, hamburgers, ice cream, donuts, but I dose for it, right? And the dose, so the amylin decreases, it's what you naturally secrete, so it doesn't, your sugar levels don't go as high, and then it's easier to treat with. Right? And you don't do it every day, right? Because you don't go to eat pizza every day. But on the days that you're going to go, you might be able to give yourself something like amylin, and then you go to that party, and you don't have no problem. Right? So I reiterate, you're no different from anyone or the guys around, or the guys, gals around. You just have to learn how to deal with it. So what we do is, we can reduce that glucose input with amylin, or something that's very similar to it, which is the glucagon-like polypeptide, which we do here. You can give episodic. Also, we're looking at a whole new class of medication called sodium glucose transporters. And the SGLT1 is what decreases the sugar that comes into the intestine. You can also reduce the after the meal sugar with amylin or the GLP-1. And that's why this is the same process here, with this, it really decreases the glucagon that's produced. And so you put less sugar out of the liver. And so those after the meal sugars don't cause it down as wild. So amylin has been available since about the mid-90s. It's called Similin, synthetic amylin, about 0.5 milligram sub-Q after each meal. So why don't we use it? Because this here, PIT, pain in the it's hard as heck to use. That's why people, they tried it, it's nobody uses it. Because after every meal, you eat a cookie and you give a shot. Eat a meal, you give a shot. I mean, it gets old fast. These are the GLP-1s that are available. We use it primarily in type 2 diabetes, which is a major issue. But these will do, they're almost like a surrogate for amylin. When you use this, it decreases the postprandial glucagon.
Are these oral or?
These are shots. But there is an oral one that's being tested, not yet available. It's called semaglutide. And we're looking at testing. I think it's released in Europe and not here. But these are shots. But the shots they're variable. The first one came out in 2005 by ETA, which is exenatide, and that was given twice a day. Victoza is once a day, works great, and it lowers the postprandial sugar quite well. And Bydureon is once a week. And then dulaglutide, albuglutide once a week. We have they actually make a tube which actually will produce this compound and push it out. And you put that in for a year.
Are they just as effective as the one once a day? The
Yeah.
once a week?
Yeah. Oh, yeah. Yeah. That's why they're released. Yeah. These are the ones that are commercially available. And then Saxenda, which is a drug we use for weight loss, is exactly the same as Victoza. And interestingly, you see the dose is much higher.
Yeah.
So if Saxenda works, you use half a dose a day, you get the same dose as you get with liraglutide. It is liraglutide. So these things are available. But then you use it episodically, depending on the pizza. Metformin is used because we now know that it actually helps secrete GLP-1. And there are some endocrinologists who are adding metformin to type 1 diabetes in the hope that it actually is doing that. But the mechanism of action probably is through the GLP-1 activity. This whole class of sodium glucose co-transporters, the SGLT1, decreases the movement of glucose across the intestine, so you absorb less. But that means that the sugar goes into your large intestine, so it's like being lactose intolerant. It causes a lot of gas. Now we have drugs that help you pee out more sugar, the SGLT2 group. which has been really amazing. We've done some of these studies where it really drops the amount of sugar that's there, so your insulin dose drops. And there are a whole bunch of them. And the interesting thing about this is when we tested it in type 2 diabetics, they actually have done these studies, which are really important studies for you to know about. In 2016, they reported on empagliflozin in type 2 diabetics that had heart disease, and it decreased the mortality rate from cardiovascular disease by 38%. That's spectacular. That's amazing. So almost half of fewer people died of heart disease, type 2 diabetes, when they were put on empagliflozin. These are the people that had heart disease. The Canvas study we just completed and they reported on this year, similar decrease in mortality. And in 2016, liraglutide, which is Victoza, they did a study with liraglutide in people that did not have heart disease, and it decreased the cardiovascular mortality by 22%, almost a quarter.
By taking
These agents, these SGLT2, yeah. It helps you pee out the sugar so there's not much sugar, and so it has advantage.
Dr. Why don't
Mortality.
we hear about these?
Well, they know about it, yeah. It's in the, this is 2016.
Dr. Chuck, don't you have to be careful though about the amylin if you're exercising a lot though? Because if you're peeing out the sugar, right, you're not absorbing it in your muscles if your muscles are using
Yeah.
the sugar. So you kind of have to be very careful
Yeah,
about,
you do.
I would think, of how much you're
Absolutely.
using amylin if you're really, really
Or
active.
this is
right?
not, this is actually empagliflozin, which is it's a different agent. This is not amylin, yeah. So take-home messages from, diabetes. If you're type 1 diabetic, there are no restrictions on how you can live. Your goal is actually to be able to titrate it, learn enough, and you can get this. Yeah, you'll be fine. And then, you need self-sufficiency is a good goal for this. And the other thing is that this is not a punitive. These are the people that I work with. That's it. Yeah, that's
Question. I call this the grandma effect.
Cool.
Grandpa.
Grandpa did?
When Will's very stable, numbers, gets around grandma, no activity. For some reason, when he gets around, I don't know, psychologically or not, or I don't know, stress or whatever, good stress, runs lower when with grandma and grandpa than when he's at home with me. Today was a perfect example.
Must be a good grandma's a good thing. That only happens with good grandmas.
I know that. I'm just saying,
We can't
it's not an
explain it,
I can't
no.
explain
Yeah,
it.
we
We
can't
call it the
explain it.
grandma
It
effect.
happens every time.
Every time.
And they're
Wow.
not,
Numbers run lower.
and usually active.
Yeah.
Unusually active?
No,
They're
not
not.
anything out of the ordinary. More
What did he
active.
do before he goes to grandma's house?
School. No PE.
No PE?
No PE. Just today was a perfect example. All of a sudden, just dropped.
The 30s.
Stuart, I can honestly tell you, I have the foggiest idea what
That's what Title is about, right? Okay.
Yeah.
Yeah.
That's something to figure out.
Yeah.
But it has to do with, are you getting it in and getting it out?
Get it out. Okay.
And so you need to try to figure out where that is. Is the insulin, is the Lantus peaking at that time? Is it in the course of, is it 12, 13, 14 hour period after you've given the Lantus dose where you have the most number of openings?
We're
Is
pump
that
driven.
the-
We're pump driven now. We're on an animus pump,
Okay,
so we're getting
that's
that.
fine.
Basal
Right,
and
but the
bolus,
basal does
yeah.
change.
Yeah.
But you need to look, because you're on either Novolog or Humalog.
Humalog.
And so that works for 4 hours. So look at that dose and see when it's, that peak is occurring. But the kinetics have to have something to do with that.
Okay.
And what I've always learned in working with people is that it's amazing once you give them a little bit background. It's amazing what you learn from people that are dealing with it. When we have studies, when we have the type 1 diabetics downstairs, when we're doing pump studies or things like that, the interaction between these people, just like with carb dieting, when you get together and you talk about them, and you have these problems that you actually deal with together, It's amazing what you learn. So it's a great problem to consider. Maybe somebody can figure it out and then help you with it. I just don't know the answer to that at the time.
Dr. Chuck, I was confused about the Amylin versus the SD1. What was
Yeah,
the
the
difference between the two?
SGLT1 is,
Or-
that's a different transporter.
Okay.
Normally, yeah, it's a sodium glucose co-transporter. And where it works in the kidney is that you put sugar into the kidney and then usually you draw it all back up. In the diabetic, you don't draw it back as much. And so with this agent, you block that reabsorption. So it doesn't go back in and then you pee it out.
Yeah.
So anything above, in this case, anything above the 100, 110 or even 90, you pee out.
So you won't spike then?
You're losing more sugar onto the kidney. Normally in a diabetic, in a non-diabetic, you lose sugar above 180 until you pee the excess out. In a diabetic, that goes up to 200 to 240 before you begin peeing. But remember, this is the kidney, so it's only dealing with not the full volume of blood, but a portion of it. But then you just take out more sugar. So here, we lower that threshold, so you kick out a lot more sugar, up to 90 grams of sugar a day, which is a lot of sugar.
So is it something that his doctor can prescribe to him?
Yeah, probably won't do it initially, because, it's you're adding the output. We've done studies where we've seen tremendous control. But it hasn't been released for type 1 diabetes yet. We have tested it, but it's not yet fully released. But the idea is that what you're doing is you're adding things to the insulin to give you better control of those variations. It still requires that you understand where the sugar's coming from, where it's going.
But it's not allowing you to spike as high.
That's right.
And you're peeing before, yeah.
It won't be high. So you're dealing with less insulin. Because insulin is, it's a growth factor too.
So the Amylin though?
Amylin actually,
Yeah.
that you normally produce, that actually works on the glucagon to push less sugar out the liver. But the amylin is naturally co-secreted with the insulin. That's a different thing.
Isn't a glucagon naturally produced within your body though too?
From the alpha cell, right next to it.
Right, but with a diabetic, type 1 diabetes, they do not produce as
Oh,
much?
no, it's fully functional.
It is fully functional?
Absolutely. Type 1 diabetes does not kill the beta cell,
Okay,
the alpha cell.
that has to do with, so when we're introducing like today a shot of glucagon, it's just giving him more
Yeah,
to
from
get
outside.
him?
It's
Yeah.
like giving the insulin
Okay,
outside.
okay.
It works on the liver. Yeah,
Can I ask you a question about
Sure.
Lantus?
yeah.
So, you were saying that it lasts 17 to 22
Yeah.
hours, and I've read that some people split their Lantus
Yeah.
because of
Cool.
that. My son isn't crazy about the idea of splitting
Yeah.
Lantus. He wants to stick with just the one. And so right now we do it right after school.
Good.
And the reason we do it then is just because we're always home, we're always having a snack, it's very predictable. But I was looking at your slide, and if it really does only last up to 22 hours, maybe it makes more sense to give it in the morning,
Yeah.
so that when it's wearing off, it's when he's sleeping, and then there's less of a chance of him going low at night.
Isn't that a great idea?
But then there's also, it's harder to monitor, because per your chart, where to find out if we're giving the right dose of Lantus, it's the change. And if it's going off between 17 and 22 hours, then you would see his blood sugar,
Come up a little bit.
but that would naturally happen,
Yes,
even if the Lantus dose is right,
You're right.
because it would be, so I'm not sure how to weigh that, both of those kind of conflicting things if we give the Lantus during the day so we can measure, because I feel like he's changing a lot right now. I feel
He
like
is.
he's in this honeymoon phase, we've already decreased the Lantus quite a bit, he's still going low a lot. So we keep just bringing it down like a unit a day, we
Yeah.
figure at some point we'll
Yeah.
hit the right number, right? But, I don't know, what do you think? Do you think the right time to give Lantus is midday or morning or?
Depends on what you're doing with, it's your,
It just,
how active is
so
your
there's,
son and when
there are
is he active?
benefits to both.
Yeah, absolutely, yeah.
Okay,
And experimenting.
It's
Okay.
all experimenting.
okay.
That's what I'm saying. And so, is it that you want to experiment, you want to set them up. So
Right.
what I'm trying to do is give you some of the basic ideas of how physiologically things work.
and then you need to set up these experiments.
So either way, it could work.
Absolutely, it does work for different
Okay.
people.
Because the morning time, I think the downside of that is that his wake-up time varies a lot
Yeah.
on a weekday
Yeah.
versus a weekend, right? He sleeps in,
Yeah.
you know,
But-
maybe
but,
3
you know,
hours later.
There are other agents that last 24 hours.
Right, you were
and
saying the
The
Tress.
Degludec or Tresiba.
I was thinking maybe I'd ask his doctor
Yeah,
about that.
the Degludec actually works, it's much more stable.
I'm surprised they don't just recommend that.
Well, they think, you know, they give Lantus and they tell you it works for 24 hours, but we find functionally that it doesn't hold. It's weird. And then, the other thing is when he's active. That's what the draw is, right? So it just changes the rate at which it changes. So that, you have to figure that into your.
Well, that would be the
equation too.
benefit of Lantus, because on some days, you're right, he exercises a ton and we decrease it even more.
Good for
And
you.
on the days that he doesn't exercise as
That's-
much, we
That's perfect.
have to,
That's
because on the
perfect.
days he
You-
exercises, he'll drop 250.
Thank you. But then
Or
now you
2
know
hours.
why,
Yeah,
right?
yes.
So now you look for that.
Yeah, no,
you
that was
adapt for
really
it.
educational.
So that's what you do,
Yeah.
yeah. This is, you want to be proactive, and so you want to anticipate where you're going.
Mhm.
And if you know how this thing works, then you can do that proactively.
Okay.
Much of diabetes has been retrospective. Yeah.
Yeah.
I mean, yeah, there's some of these cases where you look at what you did yesterday, and that's like, never made any sense to me.
Yeah.
Question, early on when we were on a pump now, obviously, we used to go on what we call a pump vacation. When
Yes.
we go to Hawaii,
Yeah,
and then we would match the Lantus dose to the basal
Yeah.
on the 24-hour. And it seemed to be pretty good.
close.
As he's going into puberty,
Yeah.
what we found is the Lantus doesn't seem to act the same. He
Good for
seems
you.
to track higher now under the same dosage and even going over traditional basal throughout the day than he was. Does hormonal changes in the body
Huge.
affect the use?
Absolutely.
Okay,
Yeah, growth hormone.
exactly. Okay, so that will affect the Lantus.
Absolutely,
Okay.
totally. And those are the things you experiment with and learn. Right. And once you get to understand them, that it makes it a lot easier. You get to understand those changes. You're lucky because you got a, you know, he's such a great kid. You know, he listens to you. He probably will never tell you that, but you know.
Yeah.
Yeah, yeah. He's got a great grandma and grandpa too. You can tell I've known them for a while.
That's the case.
Yeah. But, you know, you learn every time you do it, yeah. And the thing is, make notes and keep track of where you're going, you know. If you got a CGM now, use it to see what the trend is.
You know, you said that your son is really active. For the first time, we
Mhm.
experienced where our son plays basketball, and he played basketball. He was in a clinic, and he was in a clinic from the morning, and he got done in the afternoon.
4 days.
It was 4 days,
4
but
days.
it was a 1 day in particular.
Right.
And so it was a 4-hour solid. He
Wow.
was done in the afternoon, and he was getting ready for bed. And he was at a normal, he was within our range, the range that we like him at. And we gave him a dessert, and it didn't call for anything, so we let him go to bed. And he was lethargic, he was acting lethargic, and he was kind of flopping around, and he
Yeah.
went into the bedroom. He actually is what I consider a functioning low, where he can get in the 30s, the low 30s, and he doesn't have any signs of being low. He can talk to you, he doesn't shake, he doesn't do anything. But this night in particular, he was acting really strange, and he,
Catch that.
28. Yeah.
Oh, yeah, yeah.
and that happened right before bed.
Wow.
So
Within
just,
within
I just
15
kind of wanted
minutes,
to let
went
you
from
know.
85 to 28.
Yeah.
Yeah.
So when
With the
Dr.
dessert,
Chuck said
yeah.
that a couple of hours, we had never experienced that ever before, but it was from, I mean, he ended in the afternoon, lunchtime, and then it just seemed to catch up to
Yeah.
him when he was going to bed.
Because you need the-
Yeah, so just a
Yeah,
heads
now my
up.
son, he's a teenager, so yesterday he decided that he just wanted to see what would happen if he didn't dose
Yeah.
at all after school. Right now he only doses and eats twice a day because he hates the
Perfect.
shot. So he eats breakfast and has a shot then, a big one. And then he doesn't eat any more carbs until the afternoon when he comes home from school because he doesn't want to see the nurse, he doesn't want to do any of that. So yesterday he said, I just want to see what'll happen if I don't dose today.
So he
And I
ate.
said, okay. And so he ate his normal snack, I can't remember what it was, and we're watching it, it's going up and up, he just got a CGM too. And at one point, he was at 289, double arrow up. And he said, I think I should give myself insulin. And I said, I think you should just go to tennis and see what happens. And he was low 2 hours later without taking any insulin.
Isn't that crazy?
And-
Because exercise.
Yeah, because of tennis.
That's
So
right.
yeah.
Exercise,
So
right?
it's amazing.
Isn't that amazing?
Yeah.
Those are the things you learn and you, yeah.
Wow.
But he ended up,
Wonderful.
I did end
Wonderful.
up at some point giving him, I think, a little insulin. Just not as much as he wanted. Because now he controls, he tells me
Wonderful.
what he wants. And I'll tell him if I agree or disagree, but at the end, he makes all the decisions now. Even in this short of a time, in 5 weeks that he's had it. He likes
That
to be in control.
15-year-old, that we
He
told
was
you about.
diagnosed 5 weeks ago.
Yeah.
Yeah,
He won't give himself the shot, but he counts his carbs and he tells me how much insulin
yeah,
he wants.
perfect.
And
That 15-year-old we have, he did the
Yeah.
same thing.
yeah, he likes that part.
It's amazing,
He's-
when you have the background to know what it's doing, it's set up your own experiments you try.
Yeah.
The pizza experiments are really good.
Pasta.
Absolutely.
Anyway.
You know, if that's what you really enjoy in life, you know, learn how to, you know. I was
Yeah.
telling Leah that we had the other kid, when he was diagnosed, the family used to go out every Tuesday night to have ice cream. And so they came and they said, the first thing that they did when he was diagnosed with diabetes, they stopped that. So I says to them, why the heck do you stop that? That's your tradition. What you want to do is learn how to deal with it. And so now they're slowly going back, and they're trying to figure out, you know, how to deal with it. That's their family tradition.
Yeah.
So he'll go and pre-dose for it, and it's fine. And it's that whole, just the approach to diabetes has changed. You know, it used to be that diabetes controls your whole life.
Right.
Now we're looking at it the other way. How do you want to live? And what do we do is to allow you to live the way you want to live. That's why that first statement, there are no restrictions. You have to learn how to actually adapt to this change that are occurring. We're getting better at it. Good things ahead for you.
I went to a conference where the first speaker was somebody who, with type 1, climbed up Mount Everest.
Wow.
What he had to learn was how to keep his insulin from freezing.
Yeah.
Yeah. But he did it.
Yeah, absolutely. There are no restrictions on that.
Dr. Chuck,
Yeah.
Stuart ran into somebody that was giving himself residuals.
Oh, an inhaler.
An
Yeah.
inhaler.
Yeah, they're trying to do that.
Insulin through an inhaler. Is that as
Just a different-
effective as a shot though?
Well,
Right.
they're
Bloodstream?
testing it because it's a rate of absorption, the kinetics are a little different. But
And I
they
think
ran
it's
into
not
problems.
FDA approved yet.
No, it isn't.
No,
And
okay.
when we did some of these early studies, we had problems with the lung. Because the things that were dealing with it was causing some
Yeah,
problems.
it actually is FDA approved.
Now it
Yeah,
is.
Sanofi was selling it for a while, and now I think it's Mankind that's selling it.
Yeah,
I'm not sure
okay.
about that.
Yeah, we did some,
How
Yeah,
effective is
and
it?
it's,
it works.
you can't dose it to the same level of precision as you can through a syringe or a pump. It's in, 3-unit doses or something? And it operates much faster because it's going directly into the blood through the lungs instead of getting through the fat through a shot. So, like you were saying, the kinetics are very different.
Yeah, it's like eating marijuana or shooting or smoking.
We'll talk
But-
about that.
I don't know if that's a good analogy.
Yeah.
Oh, sorry about it.
No brownies for you.
But it's a difference in pathway. and different rates, so,
All right.
different
And,
kinetics.
and the other thing, of course, is we don't know what the long-term effect
Yeah.
is of, inhaling something over 20 years or 30 years.
It's interesting.
Most smokers do.
Most smokers do, but they're not inhaling insulin, they're inhaling tar, so.
Yeah. Thank you very much.
Thank you.
Thank you,
Thanks.
Dr. Chuck.
Good.
Where's your CGM right there?